your attention, the unsung role of the pharmacist in patient health. And this article talks about deprescribing and how pharmacists are uniquely positioned to do that, and how in Canada they're paying pharmacists to do that. And they talk about how really we have the opportunity to continue to expand our scope of practice. And down at the bottom, they also give a shout out to how pharmacists are now also prescribing contraceptives, which, as you know, is near and dear to my heart. So I'm not going to read this to you. This isn't included in the content today, but I thought it was interesting, and I thought that you guys might be interested to read about why we're really working hard to give you this expanded clinical curriculum so that you guys can go out and do cool stuff with it out in practice. So this is here for your reference. So how's the structure going to work today? Briefly, we are done with the quiz. So part one, this is an AmCare case. You guys know I'm an AmCare pharmacist. AmCare cases sometimes have less data than some of the inpatient ones. So to account for that, this will have two parts. So part one is the part you looked at home. We're going to have group review and discussion from the patient visit that's dated in the EMR as November 26th. We're going to talk about it, what you guys decided to do. And then about halfway through class, I'm going to release information for the next visit. So you'll have another audio to listen to, which is me talking to the patient when she's come in for her next visit, as well as additional data in the EMR. And then you guys will have a little time to work that up, and then we'll talk through that. So it'll be a two-part kind of situation. Do you guys have any questions about that? Okay, so framework for today. You know, my purpose for this class for you guys is to talk about how to approach a patient, right? So I really talk to you and teach this the way I try and talk to my fourth-year students on rotation and how they would present a patient. So, I mean, framework for discussion. We'll talk about the subjective, the objective, the assessment, and plan. That should be pretty basic at this point. And then where we tie it together is looking in the chart. I'll show you where I drew information out. We'll hear where you guys were looking and what you drew out. And then we'll come up with an assessment and plan. I specifically picked some disease states that you guys haven't had in the curriculum because every patient that you see isn't always going to have a disease state that we've covered in the curriculum. And you still need to be able to find evidence-based recommendations for that. So we're going to talk about that a little bit too. So for me, at the end of this class, the goal isn't to have you be an expert in yeast infections or PCOS necessarily, but to have a framework for how I would approach that in clinical practice and how you might go about making recommendations for something you're less familiar with. So you guys may have heard me say in the past, I think of notes as a learning tool or a crutch. So as you're entering your P4 year in this next part of your learning, I really expect you to segue away from your notes and to evidence-based guidelines. So I'm sure you guys know the 2019 ADA Standards of Care have come out, probably since you've had a lot of your diabetes training. And they're different, and the algorithms are new and different, and that's our new level of expected practice, and that will happen every year. So again, talking about how to use those guidelines in clinical practice and how to best leverage the resources you're given. So let's talk about Alice Whitehead and her outpatient visit. So this is our EMR, and the first problem that we're going to talk about, I'm going to go ahead and throw out, I prioritized, it's her vaginal itching and discharge. And I'd like to hear from you guys, what subjective information did you collect for this priority problem? So can we start off with Albany?
She said she had cottage cheese-like discharge.
Yeah, and itching too, right? So that's hallmarks. We talked about this your P1 year. That's very common. So in that subjective section, we're pretty much collecting things that are specifically stated by the patient. Were there any other subjective information that anybody else got? I'm going to take silence as a no. So then objective information, Augusta, what did you guys get as objective when you're working through figuring out this problem?
It looks like she's had 2 prescriptions of fluconazole for what we would assume was the same problem.
Okay, she has med prescriptions for something that's probably like this. So if you're thinking it's fluconazole, you're thinking it's something related to a yeast, right? What other information in the chart helps you narrow it to yeast? So if you're thinking about your differential, what other things can cause vaginal discharge and itching? Pain.
What?
BV.
BV, yep. What else? People often complain. STIs, good. And what was the second one? I'm sorry, I didn't hear.
What about trichomoniasis?
Trip, yep. So that would fall under STIs. And then what other common type of infection can cause genital discomfort?
UTIs, probably.
Yeah, so here in Athens, I heard UTI. I'm not sure if that went out over the microphone. So good. Those are all things that I'm kind of thinking about on my differential. So what's in this chart that helps us narrow down and figure out it's yeast, a recurrent or another yeast infection versus one of those other things? What did you guys find?
She had a positive culture back in September for Candida albicans.
Awesome. So where did you find that?
I think it was the notes section from the September 17th visit. The urine culture, yeah.
Yeah, so usually when I see a patient in the outpatient setting, the first thing I do is review all the notes that are in there for at least the 3 months prior. If they're really medically complicated, that might be plenty. If they only come in once or twice a year, maybe I need to go back more than 3 months to get a better picture. But so for this patient, when I look at her notes, she's got a history and physical that talks about a history of recurrent yeast infections, right? And a remote history of UTI. And I'm sorry, I used the word recurrent. That has a very specific meaning. I shouldn't, but she has had previous yeast infections, right? So it's noted here, good. And then she's got a urine culture. So what does this urine culture tell us? Does she have a UTI, yes or no? I'm seeing no's. So if you're saying no, why do we know that she doesn't have a UTI? She's got gram positives and gram negatives in there.
The
Tells you,
counts
right?
have to be about greater than 100,000.
Her count is low, and the lab also gives you a hint and tells you it's probably contamination just from her regular skin cells. So we checked a urinalysis back in September. It wasn't a UTI in September, and she was having these symptoms then. And then she's got this PAP, right? So what's in here? We said that she had a positive culture for Candida. Okay, great, ding, ding, ding. She's got a yeast. We don't think she has a UTI. They said that she doesn't have HPV here, HPV negative, and there's no other comment on STIs. In this case, today for class, I'm going to tell you that means she doesn't have any. We would expect to see those negative results likely in real life if they have run the test, but we're still working on our EMR and our imperfect system. We're going to move forward on that assumption today. So yeah, that's the objective information we've got in there. She doesn't have a UTI, she has Candida documented in the recent past, and she doesn't have any other signs or symptoms of the STIs that we put on our differential. Good.
Dr. Stone, can you please tell us whether or not she has the recurrent yeast infections and what would be the qualification for that?
I'm going to talk about that in the assessment, and I'm going to ask you guys, because that's part of the clinical guidelines assessment that you needed to do for the workup of this patient. So we're going to get there, and we are going to talk about that. Based on the information, the objective and subjective information that we have now, today, in November, is that she likely has another yeast infection, right? So that's our assessment. She's probably got vulvovaginal candidiasis today, and now we have to figure out what we're going to do. So then my next question is, and we could have started talking about guidelines at any point, because you're probably going to need the guidelines to help you make that assessment if the physician hasn't specifically told you she has yeast, I need you to treat her. What guidelines can you use for vulvovaginal candidiasis, if that's what you suspect?
IDSA has some guidelines.
Yeah, and you guys probably saw on my slides when I was flipping through earlier, both IDSA and CDC have guidelines for yeast infections. One of the other things that I tell students, I know the guidelines for a lot of the things that I treat, but a lot of times when I'm working up something that I don't see regularly, I may not remember what guidelines to find or use. So there's a couple different ways to go about that. I usually here, because we have resources like PubMed, go to a documented compendia like PubMed and say, hey, I think this is yeast, and have them refer me to the most current guidelines. That's a tool you guys can use too. You have access to PubMed. Most medical facilities have some type of similar compendia. If they, excuse me, I'm saying PubMed, I meant to say up to date. Most facilities will have some type of compendia that you could also use in that instance, and that's a shortcut to help you get to the guidelines faster than just Googling, because sometimes Googling won't pull up the most current thing, it'll pull up the thing that fits their algorithm. So that's one way to do that. Yeah, so for this patient, let's go take a look briefly at the CDC guidelines. I prefer them. I think they're a little simpler than the IPC guidelines to read. And also, these are what we covered in P1 year in OTCs, right? So first, we need to round out our assessment a little bit. So what type of vulvovaginal candidal infection does this patient have? Is it complicated or uncomplicated?
Is it complicated because she has diabetes?
Yeah, so you can see down here at the bottom, she has a complicated vulvovaginal infection purely because she has diabetes. Good. And then if you look over here, they talk about the diagnostic considerations. So this is some of the stuff in that objective, right? So they had the culture, and I think that they used a wet prep, the saline 10% KOH, to diagnose that. So all that looks good. I'm not going to go into great detail for diagnosis today in this one, but she fits that criteria. And then we can scroll down. They have recommendations, which we'll get to in a second. And then they talk about whether or not it's recurrent. So does this patient have a recurrent yeast infection? Someone read to me, please, or tell me in their own words the definition for a recurrent yeast infection.
She's had 4 or more episodes in a year. She's only had, this is her 3rd one, so she's not recurrent yet.
Now, by my count, this is her 3rd yeast infection that we have documented this year. So currently, this lady does not qualify for a recurrent yeast infection. So what's the recommendation for treatment of yeast? What did you guys come up? So in the plan section, just a reminder, for me in my head, I break things down. Subjective, that's what the patient told you. Objective, that's what you pulled out of the patient chart. Assessment is where you reference whatever guidelines you used. Per the CDC, this patient has a yeast infection, a complicated yeast infection, because she has had blah, 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 whatever characteristic. She's had 3 yeast infections within the past year, and she has a positive culture. It's your opportunity to explain to the person who knows nothing exactly what is going on with this patient and how you know that. And then the plan, right, that's your action list. Your plan should be pretty concise. It's your bullets. So our plan is to treat with X, Y, and Z, monitor for so many days, etc. So your plan should be almost all action items. So I feel like we've talked about assessment. Were there any questions about our assessment of this patient's condition? Okay, then let's move on to plan. I'd like somebody to volunteer what their plan is for this lady's yeast.
150 every 3rd day for 2 days.
I said fluconazole 150 milligrams every 72 hours for 3 doses.
Okay, great. And did you pull that out of here, out of the CDC guidelines?
I looked on Lexicomp, and under a vaginal candidiasis, that's what I had under complicated.
Okay. Any other recommendations?
The IDSA guidelines have a recommendation for complicated vulvovaginal candidiasis for the fluconazole 150 every 72 hours for 3 doses.
Yeah, so I mean, I think that that's a good solid answer, and that's what's commonly used. You'll see here, they'll also talk about using, especially for recurrent, a longer dose of therapy, but I think for where this patient is right now, the fluconazole for 3 doses is appropriate. This is the third one. So in clinical practice, by the time you have a second or a third one, we're almost always using oral therapy because physicians, I think, often feel like it works a little better, it's prescription. You guys remember for first-line therapy, if this was her first one or even her second one, she could use OTC miconazole or any of the other azoles. The guidelines don't prefer one or the other. So this whole big list up here at the top are technically appropriate if we're early in treatment. But she's had her third. It is more likely that we're going to go ahead and prescribe the oral therapy for her just to try and eradicate it. And I agree. I think that the 150 milligrams on day 1, 3, and 7 is appropriate. So then, what type of monitoring do we need to do? I hear words in Athens, but not through the microphone.
Improvement of symptoms.
Yeah, so this is really basic, right? Improvement of symptoms. Hopefully it doesn't come back. What other things can she do to help prevent her yeast infection from coming back? What other counseling points can we give her?
Maybe wearing a breathable fabric underwear?
Yeah, breathable cotton fabric, so lifestyle things. Making sure she's eating a probiotic diet can sometimes be helpful. And then what other disease does she have that could be contributing to this?
Diabetes.
She's got diabetes. Yeah, she probably has a lot of glucose in her urine. That's probably providing a substrate or food for that yeast. And if we can get her diabetes better controlled, we can probably also get her yeast infections better controlled. So that might be a counseling point of motivation to help her work on her diabetes control because her primary symptom is this genital discomfort right now. So sometimes using those two together can help paint a bigger picture for the patient. Good. Do we have any questions about the yeast infection? Priority problem number 1 today.
We have a question in Savannah. So on the CDC guidelines, the second paragraph under treatment is the oral fluconazole weekly for 6 months. Is that specifically for the recurrent, if the patient had recurrent candidiasis, or it's just not very clear?
That is specifically for recurrent.
Thank you.
No problem. Okay, so problem number 2. What do you guys think that this person's next most important problem is?
Diabetes control.
Yeah, diabetes. So her diabetes is contributing to the other. I think that that's appropriate. And her diabetes is fairly poorly controlled, right? Do we have any subjective information to review for her diabetes? Did she tell us anything in the interview?
The way she takes her diabetes medications.
Can you elaborate on that for me?
She stated that she takes 1 metformin in the morning and the evening and 2 glipizide in the morning and the evening, and the glipizide contradicts what the chart says as far as regimen.
Okay, what's it say in the chart?
3 in the morning, 30 milligrams in the morning, 30 milligrams in the evening.
Okay, so there's several issues there, right? So she's not taking what's in the chart, and then we might have questions about that dose that's charting. Okay? What other subjective information about diabetes?
She kept a fasting blood glucose log over 2 weeks. I don't know if it was fasting, but she kept a blood glucose log.
Yeah, so that's important to ask her whether or not it's fasting. We're going to assume for today that this is fasting, but you're right. The medical assistant who roomed the patient and put in this initial analysis for you, so that's what this is, right? The note started on November 27th. The MA roomed the patient, did a diet history for you, pulled her blood glucose log sheet, and checked her vitals. So that's already in there for you. Doesn't specifically say fasting. I'm telling you now, that's going to be fasting today. And so, yeah, her home glucose monitoring, it kind of depends on what it is, right? Whether it's subjective or objective. If she's bringing in a handwritten log sheet, some people would call that subjective. I usually just go ahead and call it objective. If she brings in her meter, I consider that to be objective data. So yeah, we have some glucose logs for her. I don't remember, to be honest. Did she talk anything about excessive urination, thirst, hunger, any signs of hyperglycemia? Did she talk anything of any symptoms of hypoglycemia? Okay, so if she mentioned any of those would be important to note, but we don't have any. So then I think that's it for subjective. What other objective information's in there besides these blood sugar readings?
A1C is 10.3%.
Okay, 10.3% A1C, yep. What else?
I also listed the glucose and ketones in her urine.
Okay. Yep. So when we're looking at labs, of course, things to pull out specifically for diabetes, I would say are the A1C that you're talking about, her blood sugars. If they did like a point of care, her glucose was 343 in clinic, right? That's pretty elevated. And then usually in this instance too, if she's on medications, I'm also looking at labs that indicate those meds are safe, right? So what meds is she on for her diabetes?
Metformin and glipizide.
Metformin and glipizide, awesome. So what labs do we need to look at to make sure those are appropriate?
Serum creatinine. Her serum creatinine
Okay, how's her serum creatinine look?
looks good.
Yeah, serum creatinine looks fine. So it's mostly kidney function that we're worried about clearing those agents, right? And then also, I look at LFTs a little bit. If somebody has really severe liver disease, you can get lactic acidosis with metformin. So yeah, there was no mention of lactic acid or liver disease, so I'm pretty positive, that that's going to be fine, but that is something that I peripherally check. Slight elevations of LFTs wouldn't be a problem, but we're talking like Child-Pugh classifications of liver disease, then we're not going to use metformin. Good. So I pulled information here out of objective, out of the lab section for objective and out of the note, and I think that that's the bulk of the important material. So then when we move on to assessment, how would you guys assess this lady's diabetes? Savannah, have I called on you guys yet? I don't think I have. Can somebody at Savannah give me their assessment, please?
Because our A1C is greater than 10 and all of our elevated blood glucose, we said that it's an uncontrolled diabetes.
She definitely has uncontrolled diabetes. And what guidelines did you use to establish that?
The ADA guidelines.
Yeah, ADA 2019 standards of care. And what's the A1C goal we're trying to meet for her?
Less than 7.
Awesome. And what's her fasting blood sugar goal? For all those readings we're comparing to.
80 to 130 or less than.
Perfect, yeah. So according to the ADA, patient's A1C is well above goal of less than 7, and the majority, I usually do a number like 10 out of 15 or however many, of her self-monitoring blood sugar readings are above goal of 80 to 130. So that defines our assessment that her diabetes is uncontrolled. What other issues that we kind of already touched on is she having with her diabetes? Is she on an appropriate medication regimen?
The glipizide dose is too high.
Okay, what's the maximum recommended dose for glipizide?
The package insert says 40, but it says that basically the max effective dose is 20.
Yeah, in clinical practice, we usually don't go above 20, and she's prescribed more than that. And then we have some discordance in what she's telling us and what's in her chart. So that's something to put in the assessment as well. A patient isn't taking what's prescribed, and there may be issues with the medications prescribed.
We have a question, Savannah. So since we said the dose was too high, was that the answer to the quiz question, or was it non-adherence because the patient wasn't taking it how it was prescribed?
I had intended it to be too high, but the correct answer is going to have to be both of them, probably. Good question. Thank you for bringing that to my attention again. Okay, so for her diabetes, have you guys checked out the 2019 standards of care yet? And the new flow chart? Because it's different than the old flow chart. It's pretty exciting.
I haven't looked at it.
I'm pumped about it. So one of the quiz questions also was, is she, let's see, how was it specifically worded? What A1C value is it appropriate to consider combination injectable therapy? What do you guys think?
10.
What's the algorithm say?
10.
Does anybody know before I show you?
10%.
10%, yeah. So there's a really nice Flow chart.
I did not see that.
So a couple things that you guys, I'm sure, are aware of with these new guidelines. They've got this awesome chart that shows you, based on other comorbidities, what type of medications are preferred. Great. So things for us to keep in mind when we're thinking about this. Does she have ASCVD? No. Does she have heart failure or CKD? No. Does she have hypoglycemia? No. Compelling need to minimize weight gain or promote weight loss? What's her BMI? I think her BMI is 39, right? Okay, so put a little asterisk by that in your brain. And then cost. Does it say anything about her, what does it say about her financial situation in the chart? Lost her job with no insurance. Okay, so these are our two that we're going to be kind of thinking of in the flow chart when we're picking her meds. And then here, let's keep rotating. I should have just gone counterclockwise, huh? All right, so here, I know this is kind of small, but you guys have the ability to pull this up on your computer too. At this top part, consider injectable combination, which could be GLP-1 plus basal or prandial basal insulin if A1C is 10% or higher. So that's our lady, okay? So we know we need to make changes to her medication therapy, right? Her A1C is 10, her fastings are all poorly controlled. I've just shown you some of the tools that I would use to help make those adjustments. So I'd like to have somebody here in Athens present what their plan was for this patient's diabetes management.
I said that we should put her on NPH 10 units sub-Q at bedtime, just by 2 to 4 units weekly to achieve fasting glucose less than 130 but greater than 80. Discontinue glipizide and continue the metformin.
Okay, so I heard start NPH, stop the glipizide, continue the metformin. There are multiple right answers to this question. Thank you for sharing your answer. I'd like to hear somebody else's answer. I'm pretty positive not everybody had that same conclusion. What else did you guys decide to do? And I'll open this up to all the campuses.
Dr. Stone, I have a question in Augusta.
Yes, ma'am.
We calculated her ASCVD risk, her lifetime risk, to be 50%. So I'm wondering, does that qualify her for that ASCVD box or no?
In this case, I would say no, not for selecting her diabetes therapy. I'd have to go back through and reread what they're considering ASCVD here, because I've only had these guidelines for about a month as well. I don't have them memorized yet. But my gut is no, we're not going to call this ASCVD because of her elevated ASCVD risk. She doesn't have clinical ASCVD, she just has an elevated risk score. She doesn't have a past history of an event or anything else of that nature documented. She's not secondary prevention. So for today, we're going to move forward with saying no, just elevated risk doesn't necessarily qualify her, and I'll do a little research and follow up with you guys via email and make further commentary there.
Thank you.
Okay, well, I'm not going to tell you what I did until I get at least 1 or 2 more suggestions. So we can either move ahead to the next problem, or we can talk about your suggestions a little more.
I chose to do a combination therapy because her A1C was greater than 10%.
Okay, what combination therapy did you pick?
Well, I know I wanted to do Victoza, but I wasn't sure. I was going to do GLP-1 agonist with insulin, but I didn't pick which basal insulin.
Okay. So we said GLP-1 Victoza with a basal insulin. What are just some of the options you have for basal insulin?
Lantus is an option.
Yep, Lantus.
Or the bio.
Yeah, Lantus. U100 is Glargine. What other Glargine products are out there? right? We have more than just Lantus now, right? The higher concentrated ones, what are they?
Together?
Yeah, we got Toujeo. And then we also have insulin Degludec, Tresiba, right? NPH can kind of be considered a long-acting insulin, but it's got to be 2 shots a day to offer that 24-hour coverage. So Bonnie, I probably would stay away from NPH as opposed to those other 24-hour insulins just because of the higher dosing requirement, right? If we're going to pick a basal insulin, I'm probably going to do like a Glargine or a Degludec as my preferred because it's just once a day shot. And then, yeah, when you're picking the GLP-1, right, this chart kind of leads you right to it. So there are footnotes down here that tell you if you're going to pick a GLP-1, pick one with good efficacy, weight loss. And then in the footnotes down here, it describes which ones those are. So like semaglutide, liraglutide, they're some of the ones that have more benefit for weight.
Dr. Stone?
Yes?
We got a question in Augusta. This patient stated last time that she doesn't have insurance, so that's why we, like, some of us chose NPH to do it twice a day.
Yeah.
She would be able to afford Lantus or any of the long-acting or any GLP agonist.
Perfect. Thank you for bringing that up. I think that I glossed over that point, and I'm glad you reminded me. So yeah, she can purchase NPH at Walmart for $24 a vial. That's totally true. And that might be a great thing to start today, and then maybe transition her to a basal insulin in the future, because this woman will probably qualify for a medication patient assistance program, right? So anything that's a branded medication, you can usually submit to the manufacturer an application saying, I can't afford my meds, and they'll give you a supply, usually a 3-month supply. That's what we do at Mercy Clinic, where I currently work, almost all of our basal insulins, and GLP-1s. So things that have gone generic, that no longer works for. But things that are branded only, like most of our insulins and all of our GLP-1s, that is an option. So that's a really great point. It's going to take probably a month to get that application in. So in the meantime, you could say, yeah, let's do NPH, a once or twice a day injection for now until we can get her application sorted out for the more desirable therapy. Good point. So we kind of have 2 options today, right? Are we going to build the ideal regimen that we want for her, or the regimen that she's probably going to be able to purchase today? And that's a really great real-life question. So I would say if we're talking about only things that she can purchase today, then yeah, I would do the NPH as Bonnie and you guys suggested. I'd probably decrease her glipizide back down to an appropriate dose, and I'd continue the metformin. And we can't do combination injectable therapy, right? Because there isn't another combination therapy to add on that we could get her that would be cost effective. Does that make sense? So that's kind of option 1. Option 2 would be designing what I would consider to be the therapeutically desirable regimen that you're going to get, but it's going to take maybe a couple weeks for those medications to come in. And that's a basal insulin and a GLP-1 in this case, probably something that will help with weight loss. Good discussion. Do you guys have any questions about that and sort of my thought process there? Nate? Can you do the mic? Thank you.
So for the purposes of testing, should we know the cheapest therapy, or do we need to know the optimal therapy? Because obviously we're not going to be able to choose both on a test or on quizzes and stuff like that.
Yeah, that's a really good question. For me, I strive to not write questions that have 2 answers. As you saw from the quiz, sometimes I don't succeed in doing that, and some questions have 2 answers. But I would say know the correct therapeutic option, and that's what you're more likely to be tested over. I won't write a question where you have to choose between choice and therapy.
So I guess my other follow-up question is, on this case, they specifically said she didn't have insurance, so it kind of biased us to pick therapeutic regimens that weren't super expensive. Mm-hmm. In the future, should we just ignore that and then just pick the one that's optimal, or should we base our entire case off being affordable?
Yeah.
I guess I'm a little confused.
Yes, thank you again for the question. In practice, I have to do both. And for the purposes of the discussion here today, I wanted you to see both. But again, for testing purposes, to keep it simple, I will tell you that the ideal therapeutic option is what you're more likely, or what you will be tested over for any of my content. Does that clarify?
Dr. Stone?
Yes, ma'am. Sorry.
Did you say you would keep the glipizide and decrease the dose?
Yes. If we were only able to start one injectable therapy today, or actually, either way, really, taking the glipizide off, it's kind of, there's no right answer there. But I would go back to the FDA recommended dosing and keep it on, especially if I wasn't able to start combination injectable therapy. There's a good chance it's not working, right? So glipizide may not work for people who've had diabetes longer than 10 years. There may just not be any beta cell function to squeeze that insulin out of. But we don't know that at this point. And in light of if we were not able to give her the desirable therapeutic regimen, I would leave it on.
And is the drug interaction between glipizide and fluconazole relevant?
No. I didn't know there was one. I use them in practice routinely together all the time. I would call that not a relevant interaction. Especially because the fluconazole is short term. Maybe if it was daily for months, but even once a week dosing, I would say is fine. Good questions. Okay, so for diabetes, we've kind of got our plans hashed out. So hopefully in a perfect world, we'll be able to move her towards her GLP-1 and her basal insulin, keep her on her metformin, plus or minus glipizide, depending on that provider's preference. What kind of monitoring do we need to do?
A1C, fasting blood glucose, self-monitoring at home, and recording at home, monitoring for hypoglycemia now that we're starting new agents.
Good, so let's take some of the logistics off of that. How often do we check A1C for people with uncontrolled diabetes? Every 3 months, right, yeah, so she needs A1C. And then does she need any lab checks to start a GLP-1 or insulin? Do we need to check anything in advance of starting those? Not really, right? Do we need to check anything after we start those to make sure that, organ function hasn't changed? No, those are pretty well tolerated. So we don't have to do any med safety checks for those. And then the metformin dose we're not changing. And we already talked about anything we're going to decrease the glipizide. So from a med perspective, not a lot of lab work to be done. From a diabetes perspective, we want to see how well controlled she is right now. And then you talked about some other lifestyle kind of checks. So yes, we need to monitor her blood sugars at home, right? And then also monitor for signs and symptoms of hyper and hypoglycemia. Good. So how often do you want to see this patient? So we're going to start her on injectable therapy. When would you see her back for her diabetes?
What question? 2 weeks? Or what? When should she come back? 2 to 4 weeks?
3 months. Okay. So if we're gonna, I think that's appropriate if we want to evaluate the dose that we start her on. Like, we're going to keep her on that dose the whole 3 months. I think that this lady's going to need to be titrated up on her insulin. So I probably would want to see her back in 2 to 4 weeks to adjust her insulin dose. If I thought that starting insulin at that dose was going to fix it, then I might check her in 3 months, but I'm almost positive that's not the case. And then usually when you're starting somebody on insulin for the first time, you still want some kind of check-in, either a nurse visit or a follow-up visit with 2 to 4 weeks after, just to make sure they're not having hypoglycemia or injection site reactions or other problems with the new med. Yeah.
Hey, Dr. Storm, I have a question.
Yes.
So this, the glipizide causes weight gain, the sulfonylureas. Do you still want to keep that on, or would you consider something else, considering her weight is trending up?
Yeah, I think eventually we want to transition off the glipizide because of the weight gain and because it's probably not effective for her anymore because of her duration of diabetes. So either stopping it now or slowly titrating down is where we're headed. And I think either stepping down or stopping today could be considered. But if we don't have so again, that's kind of the 2 parts. If we're doing the NPH, leave it on because we don't have combination therapy to give her today. If we're able to start that perfect regimen, go ahead and take it off. Would be my recommendations. Real life isn't as black and white. I think you will see both done in practice for this patient. They'll leave it on or they'll take it off. I don't have any further comments on diabetes. Any other questions or things you guys want to talk about for that disease state? Okay. What's primary problem number 3?
PCOS?
PCOS, yep, I think that that could work. Either hypertension or PCOS falls next. Let's do well, let's just get the big three out of the way. Let's go ahead and do hypertension, if you don't mind. Okay, so hypertension. Is there any subjective to collect for hypertension?
She says she's taking lisinopril as prescribed.
Good, yeah, so pretty much confirming that they're taking their meds is usually the only subjective you're going to have for hypertension unless they're really elevated, right? And they're having end organ damage because of their blood pressure. You can't feel blood pressure. Or hypotension, which again, I don't think is the case here. So for this lady, she says she's taking her meds, great. We could also be assessing for things like caffeine and other lifestyle stuff. This isn't the focus of the case today, so I'm not going to go into great detail there, but you guys know to talk about diet,